So this is the last talk before churrasco. So courage. I will speak about the dynamic MRI in ACL partial tear. It's a quantitative but also a qualitative visual analysis, and it's a new study. About the partial tear, it's always difficult to make a sure diagnosis of a partial tear. You have the clinical exam, and the most reliable test is probably the pivot shift, but sometimes the patient is difficult to do it. We use the laximetry using the KT1000 or tear loss evaluation, and you will see that you have small differences side to side. And when you look on the MRI, the first MRI, it's always difficult to make the difference between a partial tear or a complete tear, especially if you do it close to the trauma. So there is no real functional analysis for the ACL remnant, and that's quite important now because we are going more and more on augmentation of ACL surgery. So the goal of this study was to find a new technique to be reliable of the quality of the ACL remnant. We do that on 42 patients, 12 patients, normal ACL, 20 partial tears, and 10 complete ruptures. We did the clinical exam, the KT1000. This is a French device to measure it's a sort of KT1000, but more KT2000. But it's a new device, and the dynamic MRI. So you see what does the dynamic MRI. The complete ACL was diagnosed with a positive pivot shift, a soft Lachman, KT1000 side to side more than 3 mm, and the partial tear, no pivot shift or mild pivot shift. And we always had a mismatch between the Lachman test and the laximetry evaluation. So we used this device, which is a pneumatic orthosis, which is put on the anterior part of the limb. We put that before putting the patient in the MRI. It's also MRI compatible, and we have a remote control which we can use on the MRI desk. And this will, you will increase the pressure in this orthosis, and this will create anterior drawer. The MRI exam is done in the 3-plan, one sagittal sequences with the anterior tibial translation, and we will measure the anterior tibial translation, and the dynamic sequences with a video analysis where you can see exactly how is the ACL remnant and how this ACL remnant is put in tension. You will see that you see perfectly how is this the ligament. So we first measure the medial translation as we do on the normal X-rays, taking the posterior part of the femur, posterior part of the tibia, and we measure the value. It's of course not a side-to-side value; it's an absolute value. And then we measure the lateral translation, and we will probably we try to understand if we can measure the rotational instability in using this type of device. So on the dynamic sequences, we will see the tension and the fibers evaluation. And for the red one, for example, you see that there is no distension. So it means that this ACL rupture is nearly not it is a real rupture, and you still have a bundle really efficient because it doesn't move too much. On the grade 2, you have you have the tension, it moves, it increases the anterior tibial translation, but it stopped. So it means that the partial tear is there is an elongation of the ACL remnant or the ACL bundle, but it's still efficient in terms of functional things. And the grade 3, when you push the tibia, you have a global distension. We call that the chewing gum or the gum aspect. It means that the fibers has a high distension and a high elasticity. About the results, they did the reproducibility intra and inter-observator, and it was good and it was quite reliable. Why the patient, why the doctors, the radiologist and the sports medicine doctor who did this study were trained with this exam, of course. Drawer measurement are really easy to do and to position, and the ligament elasticity evaluation also is quite easy to rate. So we did a correlation between the video analysis of the ACL remnant and the objective in laximetry using KT1000 and this device, which is called the GNRB. And we had a quite good correlation between those three things, and we could determine some threshold for the medial translation and the lateral translation, 1.1 millimeter and 2.8 millimeter. So you see that we also always have more translation on the lateral compartment than on the medial compartment. What was important and really interesting, and for the surgeon, it's the best things we can have, is on the partial group, the clinical partial group. We found a high variability in the aspect of this ACL. It means that when you make a diagnosis of a partial tear, clinical, and you go on surgery, you can decide before doing surgery to do an augmentation or a partial repair of your ACL, but you really need to go in the joint with a scope, probe the ACL remnant to see if it's a good quality or if it's a bad quality. And it makes the difference between ACL remnant with a good quality and bad quality. And maybe we can do, it's like a MRI scope, and make the difference between the good partial ACL tear and the bad partial ACL tear. It's also something which can do a prognosis to your patient and say to your patient that maybe this partial tear will re-rupture within 1 year or within 2 months. So these are some different cases. We do sagittal cuts, coronal cuts also, and you see the distension between this ACL and this one, and you will see that the laxity is quite high, 6.4 millimeter. You see also the tension of this ACL over there, and on the video analysis you will also be able to rate the elasticity of your remnant. And this ligament is present, is here, but it's not really efficient because the distension of the whole ligament is too high and the anterior drawer is too big. It's a grade, what we call a grade 3. We have also these two other examples. This is with no drawer and with drawer. And I think that the video is after that. You see this one, you have a good tension, and the fibers are still here. The signal is a good signal, and if you go on this one, you see that the anterior drawer is higher, but you can also see that the signal is getting less good at the proximal part. So this one will be efficient, and this one won't be really efficient. So as a conclusion, we can say that this dynamic MRI is a good reproducibility. It's really easy to do. It could be accurate for ACL rupture, and I think that more we will make analysis or partial tears, more we will be accurate in the diagnosis of a good remnant and a bad remnant. It's not a long time exam, because it adds 7 minutes to the normal exam, and maybe this could allow us to tell the patient what is the prognosis of his partial ACL tear, and also to schedule partial augmentation or a normal ACL plasty. Thank you very much.